350, 400, 450. But if it becomes 300, then you should consider it is one of the criteria of acute respiratory distress syndrome. These all points should be met. The third point is chest imaging, which will be showing bilateral opacities and which are not explained by effusion, atelectasis, nodules, or which are not explained by cardiogenic nature. So if you have a chest X-ray, there are opacities, bilateral opacities, and you can't say that whether this is effusion or atelectasis or nodule or it is not cardiogenic in nature, then you should consider that one of the criteria of acute respiratory distress syndrome. Then the last one is pulmonary edema, not fully explained by cardiac failure or fluid overload. The patient comes in a pulmonary edema, and the cardiac output is normal, and the patient is not having fluid overload, like there is no peripheral edema, then you should consider that this pulmonary edema is due to acute respiratory distress syndrome. So all of these four should be met while defining the patient to have acute respiratory distress syndrome. So how will you manage acute respiratory distress syndrome? These are the treatment goals: maintain oxygenation while mechanical ventilation. Acute respiratory distress syndrome network goal is keeping the partial pressure of oxygen between 55 to 80 mm of Hg or saturation between 88 to 95%. You should avoid ventilator induced lung damage like pneumothorax, etc. And this can be done by using protective ventilator setting, that is low volume and low pressure settings. We will discuss it later. Third point is that maintain a neutral or negative fluid balance in hemodynamically stable patient. This sentence means that you shouldn't overload the patient. The volume status can be measured by keeping central venous pressure between 4 to 8 mm of Hg and urine output of 0.5 ml per kg. Then you should identify and treat the SARS-CoV-2 infection. So regarding ventilation, minority of the patient can be managed with non-invasive ventilation, like with the nasal cannula with high flow oxygen, humidified high flow oxygen. But most of the patient will need mechanical ventilation. Try to avoid, these are few points which should be avoided. That is, positive pressure airway devices should be avoided. That is, don't give CPAP and BiPAP to these patients. Chest physical therapy and oscillatory devices should be avoided. Oral and airway suctioning should be avoided. Sputum induction should be avoided, and bronchoscopy in spontaneously breathing patients should be avoided. Why these things should be avoided? Because these can spread the infection. These can cause aerosolization of the sputum and can cause spread of the infection. Use negative pressure isolation rooms to limit the infection within the isolation rooms and not spreading it to the outside. So negative pressure isolation rooms should be used. So when you have to intubate the patient, there is also criteria. So intubate the patient if the condition is deteriorating rapidly, that is over hours. If the patient condition is not improving with high flow and high concentration of oxygen, that is more than 40 liters per minute of oxygen, and the fraction of oxygen in inspired air, keeping it above 0.6 or more than 60%, if the patient is still deteriorating, then you should intubate. You should know that the room air contains fraction of oxygen of 0.21, that is 21% in room air. If the patient is evolving hypercarbia, you should intubate. If the patient is hemodynamically unstable, or there is multi-organ failure, like patient is the renal functions are deteriorating, urea creatinine is rising, then you should consider intubation. It should be noted that intubation is a high-risk procedure, and it can cause droplet dispersion. So it should be done by an expert with caution and with a controlled environment. Regarding mechanical ventilation in acute respiratory distress syndrome, it is important for the ventilator settings to be certain strategies should be made for the ventilator setting, because it is the mainstay of the treatment of acute respiratory distress syndrome in COVID-19 patient. So three important strategies while ventilating patient in acute respiratory distress syndrome has clear-cut mortality benefits in different studies. One is low tidal volume, low pressure settings. These are protective settings. We will discuss it. Then paralyzing the patient, it has mortality benefits. And then prone positioning. Prone positioning means that the patient should face downward. The face of the patient and the abdomen of the patient should be towards the bed most of the time of the day during ventilation. It has mortality benefit we will see. So these are a few studies which have shown that these measures and these strategies have clear-cut mortality benefit. One study published in New England Journal of Medicine showed that mechanical ventilation using a lung protective strategy of either low tidal volume ventilation or low pressure ventilation decreased mortality from 41 to 30%. So if you have seen the monitor of a ventilator, there are different knobs. One of the knobs is show for the tidal volume. So it is better to keep the tidal volume on 5 ml per kg. And there is also another knob which is showing PEEP. PEEP is positive and expiratory pressure. Keep this PEEP on 5 mm of Hg. So these are the low tidal volume and low pressure settings, and these are beneficial while treating a patient on mechanical ventilation. Then deep sedation and paralyzing the patient decrease oxygen consumption during mechanical ventilation, and there is clear-cut mortality benefit, which has shown in many trials. One of the trial which was published in New England Journal of Medicine. The third strategy, which is prone positioning, improves the mortality in severe cases of acute respiratory distress syndrome. Keep patient in prone position in 17 to 18 hours a day has clear-cut mortality benefit.